is brought to you by GPCanShare at St. Vincent's Hospital. So before we get into the speakers, I just want to give a brief outline of the project and how you and your patients can benefit from being involved. So first, I just want to introduce the team. So on the left, you can see Dr. Megan Barnet and Dr. Megan Crumbaker. They're the medical oncologists that are involved with the program. And then Dr. Orly Lavee is our haematologist. On the right-hand side, you can see the nursing team. So in the center, we have Simone Ray. So she's the GP Cancer Support Line CNC, and she will talk a little bit more to that later on in the evening. On the right-hand side, we have Susan Stapleton. She's the Hematology and Bone Marrow Transplant CNC. And then that's me on the left, and I look after medical oncology patients who are included in the program. So the two main aims of the project that were laid out by the PHN is to ensure GPs receive timely access to information and to provide specialist expertise so that they can care effectively for their cancer patients in the community. St. Vincent's are working towards these aims by ensuring existing communication channels are in place and working with administrative teams, both in-house and at these practices, to ensure that correspondence is being received by GPs in a timely manner. One of the most important activities of this project is to encourage two-way communication, and we invite GPs to use the GPCanShare team to access cancer care for both new and existing patients at the Kinghorn Cancer Centre. Susan and I conduct practice visits to GPs all around the central and eastern Sydney region, and we've conducted about 40 to date, so some of you online may have already met us. This is a great opportunity to network with primary care providers and to address specific topics that may be of relevance to individual practices, such as referral pathways, service navigation, and accessing resources. As you all know, obviously, we're here tonight and we're running these CPD events as well, and that's to share current evidence-based information on cancer-related topics and to provide you, the audience, with the opportunity to ask questions at the end. This is our second CPD event since GPCanShare commenced at St. Vincent's a little over a year ago. So that's just short and sweet of what GPCanShare is at the Kinghorn Cancer Centre. Please don't hesitate to get in touch if you'd like to arrange a practice visit, or if you have any cancer related questions, you can use the email or give either Susan or I a call. And as I said, you'll hear more about this cancer support line as well. Thanks, everyone.
Thanks, Mary, for that overview. And just to add that the GPCanShare service is available to GPs and practice nurses within our region. And if you need more information, it's on the CESPN webpage under Cancer Management. Our second presentation this evening is by Dr. Orly Lavee, who is a consultant haematologist at the St. Vincent's Hospital and the Kinghorn Cancer Centre. Dr. Lavee holds dual fellowship with both the Royal Australasian College of Physicians and the Royal College of Pathologists of Australia. And we're lucky to have her present tonight on an update on myeloma. Thank you, Orly.
Thanks, Rebecca, and thanks for the introduction. So today's talk is going to be about myeloma and an update on how far we've come with myeloma and what we're doing to manage myeloma both in the outpatient setting and in the community. And myeloma certainly is a very different disease today compared to even 10 or 20 years ago. It's been one of the fastest moving areas in haematology research and practice. And the patient journey and indeed survival have improved significantly with increased treatment options, more effective and tolerable outpatient regimens, and better supportive care. In many patients, it can now be thought of as a chronic disease that patients can live with for years because of its relapsing and remitting course. However, it's still classed as an incurable disease. Next slide, please. So plasma cell disorder encompasses a huge variety of diagnoses, and these include the monoclonal gammopathies of undetermined significance, the monoclonal gammopathies of clinical significance, most notably of renal significance, smoldering myeloma, and symptomatic myeloma. There are other plasma cell disorders, including plasmacytoma, which represents solitary or multifocal deposits of malignancy, of plasma cells in the absence of myeloma, AL amyloidosis, and POEM syndrome. We're not going to, next slide, please. We're going to specifically focus on myeloma and the precursor states today: monoclonal gammopathy of uncertain significance and smoldering myeloma. The pathogenesis of myeloma is complex, but it's thought to be a two-step process. First, monoclonal gammopathy of undetermined significance, or as we call it more commonly, Mgus, develops as a result of genetic changes, possibly the result of abnormal response to antigenic stimulation. A second event then occurs, resulting in the accumulation of tumour cells, and then finally progression to multiple myeloma. End organ damage, when it occurs, is either related to infiltration of plasma cells into the bone or other organs, or to kidney damage due to excess light chains. Next slide, please. So the first subtopic I'll cover is monoclonal gammopathy of undetermined significance, or Mgus. Next slide, please. In terms of definitions, there are three distinct forms of monoclonal gammopathy of undetermined significance, each of which have different rates of progression and which can progress to different plasma cell dyscrasias. All patients with Mgus must have less than 10% plasma cells on bone marrow biopsy and no evidence of end organ damage related to their dyscrasia or their lymphoproliferative disorder. And in addition to this, patients with non-IgM and IgM monoclonal gammopathy of undetermined significance must have a serum paraprotein of less than 30. If there's progression of an IgM Mgus, that's usually to Waldenstrom's or amyloidosis, and we're not going to discuss those today. It's beyond the scope of what we can cover. Light chain Mgus is defined as an abnormal free light chain ratio and increased free light chains with no detectable paraprotein. Non-IgM Mgus and light chain Mgus, excuse me, typically progresses to Mgus, but may also progress to AL amyloidosis or plasmacytoma. Next slide, please. The incidence and prevalence of Mgus, excuse me, increases with increasing age, and it's seen in 1.7% of people between the age of 50 to 59, and increases to 6.6% of people aged 80 and over, and it's more common in women and in African Americans. Next slide, please. The risk of progression without accounting for death due to competing causes was 10% at 10 years, 18% at 20 years, and 28% at 30 years, 36% at 35 years, and up to 36% at 40 years. So what we generally quote patients is approximately 1% of patients per year will progress. And I emphasize to people that that's the minority because it's quite daunting to a lot of people to receive this kind of diagnosis. The risk of progression seems to be higher in patients with an abnormal serum free light chain ratio, or if their paraprotein at the time of diagnosis is greater than 15. Next slide, please. So then along the continuum of disease, the next stage of plasma cell dyscrasia is smoldering myeloma, or asymptomatic myeloma as it's sometimes called. Next slide, please. Smoldering myeloma is diagnosed in patients who don't meet the diagnostic criteria of Mgus, in that they don't have a paraprotein of greater than 30 or bone marrow plasma cells of 10 to 60%, but do not have end organ damage related to myeloma or amyloidosis. So as seen here, a diagnosis of smoldering myeloma is associated with a higher risk of transformation to multiple myeloma than the rate of transformation from Mgus to myeloma. And the overall risk of progression among patients with smoldering multiple myeloma is variable depending on the time since diagnosis, and is approximately 10% per year in the first 5 years, 3% per year in the next 5 years, and it decreases to 1% thereafter, which is really about the biology of the myeloma. So if you haven't progressed in that first 5 years, you're less likely to progress after that. But that first 5 years is relatively high risk. Next slide, please. There are a number of risk prediction models available to predict the progression of smoldering to symptomatic myeloma. The two most popular ones are by the Spanish group, which was published in the Mayo, and they both utilize the serum paraprotein, the serum free light chain, bone marrow plasma cell percentage, and high risk cytogenetics. And the 2-year progression-free survival in the low-risk group is only 8%, while the risk in the high-risk group is 59%, so quite high. Next slide, please. So then we come to myeloma. So we do work along a line of progression, and there is a bit of grey zone between the three. Next slide, please. So multiple myeloma, as I alluded to earlier, is an incurable hematological malignancy that's defined as having greater than or equal to 10% of plasma cells or an extramedullary plasmacytoma with one or more myeloma defining events. And the traditional myeloma defining events, many will remember from medical school, and they're outlined by the cheat sheet of CRAB, which is CRAB, hypercalcemia, renal impairment, bone lesions on skeletal survey or PET-CT. In 2014, the International Myeloma Working Group updated their diagnostic criteria to include 3 new myeloma defining events. And this is because the presence of one of these events was associated with an 80% risk of progression to the previously defined symptomatic myeloma over the ensuing 2 years. And these included clonal bone marrow plasma cells greater than or equal to 60%, a serum free light chain ratio of greater than or equal to 100, and greater than 1 focal lesion on MRI. Next slide, please. According to data from the Australian Institute of Health and Welfare, in 2015, there were 1,885 new cases of myeloma diagnosed in Australia. And the risk of an individual being diagnosed with multiple myeloma by their 85th birthday was 1 in 85 for females and 1 in 129 for females. Sorry, for 1 in 85 for males, 1 in 129 for females. Myeloma seems to be increasing in incidence in Australia. There were 567 new diagnoses in 1982 compared to 1,885 in 2015. And that's probably reflecting an increase in the awareness, increase in screening practices, and greater access to laboratory investigation over time, particularly for older patients. Next slide, please. The greatest risk factor for multiple myeloma seems to be age, as demonstrated by this incidence graph from the UK cancer data. The mean age of diagnosis is 70 in Australia, and that's not to say that young people don't get myeloma, but it is much rarer and they do tend to be more high risk in terms of cytogenetics. Myeloma is also known to vary by ethnicity, and African Americans and Black people from Africa have a 2 to 3 times increased incidence of multiple myeloma. And other risk factors include male sex with a 1.4-fold increased risk, family history, with persons with first-degree history of multiple myeloma have a 3.7 times increased risk, and clearly a personal history of an Mgus puts patients at higher risk. Next slide, please. So now I'd like to move on to some more practical features about myeloma. And the first thing I'd like to do is talk about how we work up a new myeloma who's come to the clinic. This is my usual laboratory and radiology workup for patients referred for assessment with suspected myeloma. And these investigations are usually done concurrently. However, I'm going to step through them in order to discuss why we're doing each investigation. Next slide, please. Initially, you need to make the diagnosis, which primarily involves performing a bone marrow aspirate and trophine. And the reason for that is to enumerate the plasma cell count, or see how many of the nucleated cells are actually abnormal plasma cells. The bone marrow aspirate will usually be sent for flow cytometry to identify that it's a clonal population and to look for any aberrant cell markers. And it's also sent for FISH and cytogenetic analysis, and that's really for prognostic purposes. A blood film should be reviewed in conjunction with the bone marrow biopsy to ensure that the patient doesn't have plasma cell leukemia, which is classified as circulating abnormal plasma cells. And serum paraprotein needs to be quantified by electrophoresis and immunofixation, and serum-free light chains should be performed. Now, obviously, not every patient with a paraprotein who is referred for assessment needs to undergo a bone marrow biopsy, but a bone marrow biopsy is recommended in patients with a paraprotein of greater than 15 grams per litre, an IgA Mgus of any size, and patients with abnormal serum-free light chain ratio who have abnormalities on the full blood count, serum creatinine, calcium, or in imaging. Next slide, please. So this is just an illustration of the serum electrophoresis and immunofixation, the actual laboratory results that get spat out when we put serum in. The serum electrophoresis is based on the migration of different sizes of proteins, and it allows us to measure the quantity of the abnormal protein. And immunofixation allows us to subtype according to IgG, IgA, IgM, and whether it's kappa or lambda restricted. Next slide, please. This is a pretty picture of some ugly cells. So the cells of interest in this slide, you can see with the arrow, are abnormal plasma cells. And the features of these cells, first of all, you can see there's a lot of them. The nucleus is eccentric, which means it's placed off to one side. And if you can appreciate that next to the nucleus, there's a very clear area. So that's quite typical. It's called a perinuclear HOF. These are actually mature cells. So the chromatin in the nucleus is of a mature cell. They're not like blast cells, but under the microscope, they're very typical. They've got a very blue color, and they're often quite large and bizarre looking. Next slide, please. So you need to determine if a patient has a myeloma defining event. It's very relevant in terms of what you do next. And we do that as per the International Myeloma Working Group, which we discussed previously. In addition to these things, I also screen every patient with troponin and pro-BNP, and that's really to look for any clues that there might be concurrent cardiac AL amyloid, which does occur in some patients, and sometimes the pro-BNP can be significantly elevated. Next slide, please. In terms of imaging, the recommendation of the International Myeloma Working Group is that all patients undergo a CT skeletal survey at diagnosis to evaluate the extent of bony disease at a minimum. And in addition, they do recommend that patients who have access to PET-CT or are within clinical trials should undergo PET-CT, as this has been demonstrated to have prognostic implications based on the number of lesions and the extent of bone marrow infiltration. Now, unfortunately, at the moment in Australia, PET-CT is not PBS reimbursed for this indication, so patients are generally out of pocket if we choose to proceed to this. Patients who have a negative CT skeletal survey should undergo whole body MRI, however. And the reason for this is the presence of lesions on MRI, irrespective of the CT imaging, is considered a myeloma defining event. Next slide, please. So you also need to identify the disease markers which you're going to follow during treatment. And these are a surrogate for how the patient is responding. And these may be a paraprotein on EPG, IEPG, a Bence-Jones protein on urine assessment, an elevated serum-free light chain, the bone marrow plasma cell percentage, or skeletal lesions or extramedullary lesions on imaging. Next slide, please. And finally, you need to collect data that's going to help you provide prognostic information to the patient. Albumin, beta-2 microglobulin, and LDH are all used in prognostic scoring systems. And it's important that FISH is performed for high-risk markers, and those that we know of include the translocation of T414, which is the IGH-FGFR3 translocation, T1416, which is The translocation 1114 is not a high-risk marker in myeloma, but we do see it frequently in plasma cell leukemia, but it can have therapeutic implications. So it's also useful information, particularly if we're considering using a drug like venetoclax in the future. Next slide, please. This is the Mayo risk stratification for multiple myeloma, which stratifies high-risk genetic abnormalities, excuse me, including deletion 17p, translocation 414, 1416, 1420, and gain of 1q, and the standard risk myeloma, including trisomies 1114 and the 614. Next slide, please. This is another laboratory picture. On the left, you have a conventional karyotype, and it takes a lot of practice to look at these analyses, but with the eye of faith, you can see that there's a small bit of material from chromosome 11 and a small bit of material from chromosome 14, which have done a switch, and this is a translocation 1114. On the right, that's how we analyse fish studies. So there's a tag or a fluorescent marker that's attached to the gene of interest. And when the translocation occurs, you get a fusion gene. So you get a mixture of the two colours sort of end on end. And that's a positive fish study for translocation 1114, which is used to confirm the conventional karyotype. Next slide, please. The most commonly used prognostic system for multiple myeloma is the Revised International Staging System, or the RISS, and that incorporates beta-2 microglobulin, albumin, the serum LDH, together with the fish findings. And it's revised because it's been amended to include genetic findings, which, as with a lot of hematological malignancies and other malignancies in general, has been found to have enormous prognostic implications. Next slide, please. The incorporation of the FISH results and the LDH into the previously used international staging system was based on clinical and laboratory data from over 4,000 patients enrolled in 11 clinical trials. And it clearly separates patients into three groups. The median overall survival was not reached for patients included in stage 1, but it was 83 months for patients in stage 2 and 43 months for patients in stage 3. Next slide, please. So the treatment schedule for transplant eligible patients typically follows the pathway of an induction therapy, followed by autologous stem cell transplantation, followed by maintenance therapy. And there's an important role for supportive care. All patients with multiple myeloma commencing active therapy should receive a bisphosphonate, and that's regardless of whether they have bony disease at diagnosis. And this is because it's been shown to prevent skeletal related events and associated morbidity, but also because there's a potential survival advantage, and it's postulated that there's some anti-tumour activity or anti-myeloma activity on the part of the bisphosphonate. So these patients need to be assessed for any requirement for major dental work prior to commencing a bisphosphonate. And that's because of the rare but significant complication of osteonecrosis of the jaw, which can be seen with the bisphosphonates that we use. Next slide, please. So induction therapy is given prior to transplant, and the goals of induction are to control the disease quickly, achieve high response rates, minimize toxicity, and achieve an adequate stem cell harvest so that you can then proceed to an autologous stem cell transplant, which I tell patients is sort of like an immune system reboot. The standard of care for induction therapy as of 2020 is combined lenalidomide, bortezomib, and dexamethasone therapy. Next slide, please. So this is a slide which is not necessarily important for its detail, but it outlines the important drug classes that we use in myeloma in clinical practice, many of which you'll be quite familiar with because patients will be coming into clinic. We tend not to use much thalidomide anymore because we have newer IMiDs, which are lenalidomide and pomalidomide. But again, a lot of patients on bortezomib, a lot of use of high dose steroids, and you'll probably see the toxicities that you would expect from high dose steroids in your clinics. But of the bread and butter drugs that we use, the most commonly cited toxicities that we see are peripheral neuropathy, venous thromboembolism, neutropenia and thrombocytopenia, and then more rarely issues with cardiac function and renal function and pulmonary hypertension. Next slide, please. So upfront autologous stem cell transplantation remains the standard of care in transplant eligible patients, and repeated randomized studies employing consolidation therapy in an attempt to eliminate the need for autologous stem cell transplantation have demonstrated that that transplant remains superior with regards to progression-free survival, and in some studies, overall survival. So the most relevant of these studies is the IFM 2009 study, which was published in the New England Journal in 2017. And that's because in that year, combined lenalidomide, bortezomib and dexamethasone was listed on the PBS in Australia. And this study, in this study, all patients received 3 induction cycles of VRD, followed by stem cell mobilization and collection. And then they were randomized to receive either 5 cycles of RVD consolidation or a melphalan conditioned autologous stem cell transplant, followed by 2 further cycles of VRD. And then after that, all of those patients received maintenance lenalidomide for 12 months. And there was a median follow-up of 44 months, and the median progression-free survival was 50 months in the transplantation group and 36 months in the group that did not undergo upfront autologous stem cell transplant. Next slide, please. So the next question is, how do we define transplant eligibility? And it was previously defined as an age of less than 65, but clearly there are older patients who can tolerate high-dose chemotherapy. And consideration of transplant eligibility also includes comorbidity, exercise tolerance, and frailty. So I won't go into the detail there, just next slide, please. Following autologous stem cell transplantation, continuation of lenalidomide maintenance therapy has been demonstrated to improve progression-free and overall survival. And many patients will be on maintenance therapy for many years. It's generally given until disease progression or it's no longer tolerable. And as mentioned, the most common reason that it's not tolerable is either peripheral neuropathy.
Orly, I think we're having some audio issues.
Sorry.
You okay? Thanks.
Yeah. Okay. So then the question is, what options do people have if they're not transplant eligible? And most commonly, those patients will receive lenalidomide, bortezomib and dexamethasone, just as the transplant eligible cohort would, but not followed by transplant. And alternatively, a lot of people just have lenalidomide and dexamethasone continuously until disease progression. Again, the choice depends on frailty or comorbidities and also patient preference. I see a lot of regional and rural patients, and it can be quite prohibitive for these patients to travel into a larger regional centre to receive subcutaneous or intravenous therapy. So a lot of people actually prefer oral therapy. And then there are people for whom supportive care alone is the most appropriate choice. And that would include the use of bisphosphonates, intravenous immunoglobulin in order to prevent recurrent infection, and radiotherapy or surgery if there are problematic bone lesions in particular, or large plasmacytomas. Next slide, please. So by means of background, from the data available in the myeloma and related diseases registry, the median overall survival of patients aged 70 and over diagnosed with multiple myeloma in Australia is 44 months. And this is sobering data as compared with the patient population in 3 prospective European trials used to generate the frailty score. Even the patients deemed to be the most frail had a median overall survival of 57 months. And next slide, please. So the nature of myeloma is that it is a relapsing remitting disease, and there is no specific pathway for relapse disease. The decision that we make in what treatment regimen comes next takes into account what drugs the patient has had before, what they've been exposed to, their previous toxicities, how long they responded to that previous regimen, and how quickly they've relapsed, and also obviously their clinical status. We are in this situation, as with every situation, limited somewhat by what's available on the PBS in most instances, and outside of clinical trials, obviously. And the options really are using the same combinations of the drugs outlined before, with daratumumab now available in the relapse refractory setting, which has been quite a game changer, but it's only available at first relapse. Pomalidomide and carfilzomib are also quite commonly used these days in the first or second relapse. Next slide, please. So I'm going to talk a little bit about what's coming and what is starting to be used quite commonly in myeloma, because it's quite exciting, and a lot of these are very novel agents with different targets to what we've used previously. There's an emerging role for immune therapy in the treatment of multiple myeloma, and this diagram illustrates the different targets on the myeloma cell, including CD38, SLAMF7 and BCMA, and the different therapeutic targets that have been developed in order to target these proteins. Next slide, please. So on the left, we have the simple monoclonal antibodies, daratumumab and isatuximab, and they bind directly to CD38. So they do this as many monoclonal antibodies do, such as rituximab, and then by a variety of mechanisms, they induce myeloma cell death. Daratumumab has well-proven efficacy in relapsed and refractory disease, and is now being studied in the upfront setting. And there's a recently published study called the Griffin study, and that's added daratumumab to the current standard of care VRD, and it has demonstrated an improved response rate. Next slide, please. The next type of immunotherapy are the antibody drug conjugates. And these are similar to monoclonal antibodies in that they target a specific molecule on the myeloma cell surface. And in this case, it's BCMA, but they're linked or bonded to a chemotherapy agent. And when they bind to the chemotherapy, when they're bound to the myeloma cell, the chemotherapy agent is then able to gain access to the cell and can target the myeloma cell and kill it. One of these molecules is called belantamab, and it has some promising results in studies in relapsed and refractory myeloma patients. Next slide, please. The next class is called the BiTEs, or the bispecific T-cell engagers, and they're also being trialled in myeloma. They're small molecules that bind to a molecule on the myeloma cell, and here it's a molecule called BCMA, and then again to a molecule on a T-cell. And so they bring the two cells together, and then the T-cell is able to kill the myeloma cell. And again, there are very encouraging results in early trials in the relapsed and refractory setting. Next slide, please. And finally, many of you would have heard of CAR T cells, or chimeric antigen receptor T cells, and this has been a very exciting development in haematology, in not only myeloma, but in other malignancies such as leukemias and lymphoma. And CAR T cells are genetically modified T cells that express a receptor on the surface that binds to a protein on the myeloma cells, and as a result of the binding, there's activation of the T cell that leads to the myeloma cell's death. And there are a number of trials in the relapsed and refractory setting. And one of the problems with CAR T cells in myeloma is that although there are good response rates, these responses don't tend to be durable yet with the regimens that we have. And more than 50% of patients will relapse within 18 months. So there's many ongoing studies in order to try and optimize this response. But progress is being made in that field, and I think it's going to be a much more widely used manipulation in the future. We tend not to allograft patients in myeloma very often anymore, and that's really because we have so many other better, less toxic therapies, and allogeneic stem cell transplant in myeloma has always had reasonably dismal results. So there will be rare patients for whom it's appropriate, but generally speaking, it's not done often at all. Next slide, please. And that brings me to the last part of my talk, which is really how you're going to encounter these patients in the community. And the vast majority of patients who are receiving some form of treatment for their plasma cell dyscrasia will be closely followed up by their haematologist. And they may have regular contact with a specialist nurse who acts as a care coordinator. How often they are seen in clinic or how often they have bloods and imaging is very variable. And it depends on the type of treatment and how long they've been on that particular regimen and their stage of disease. But most of the time, patients will be prescribed some form of prophylactic medications whilst they're on treatment. And the most common ones are Bactrim, and that's to prevent PJP pneumonia, valacyclovir to prevent shingles. Most patients will be on aspirin, usually low-dose aspirin if they're on an IMiD, or if they've had a previous thromboembolic event, they may be on full anticoagulation. And that's to mitigate the thromboembolic potentiation of some of the drugs that we use in myeloma. If there's a large tumour burden or renal impairment, patients may be on allopurinol. And we do tend to use a lot of both opioid and non-opioid analgesia, particularly in the initial stages and in the terminal stages of the disease, obviously. Next slide, please. So that's all I wanted to talk about today. I wanted to thank Dr. Georgia McCorn, who's given me some diagrams for the slides, and also very much thank the patients with myeloma that we see who contribute to ongoing data collection and clinical research, and their families who offer support. Happy to take any questions.
Thanks, Orly. We've got 3 questions, I'm assuming from general practitioners. The first one is, in general practice, what symptoms would alert us to screen for myeloma? What is the initial screening test in order to order in general practice setting? And the third part of that question is it EPG/IPEG/serum-free light chains?
So often the first clue that you have to someone having myeloma is a biochemical abnormality. They may actually be quite well. And probably the most commonly seen ones would be an anemia, a new anemia without an explanation, or a raised total protein. Often the total protein is markedly raised with no other clues. And you're quite right, the diagnostic test is a serum electrophoresis, immunofixation, urine electrophoresis, and serum-free light chain assay. I don't know, Rebecca, if you can go back to my slide that outlines the testing algorithm. But there are quite a few tests that I mentioned there that are important for diagnosis, for monitoring, and also for prognostication. Keep going back a little bit. Yeah, so that one. And each of them serves a particular purpose, but really the aim of the game is to make the diagnosis, look for end organ damage, and provide prognostic information.
Okay, great, thank you. And the second question is, when test results show elevated either Lambda or Gamma, but the ratio is normal, should these patients be referred to a specialist or should they be monitored in the GP setting with yearly blood tests?
Yeah, it's a good question because there are a lot of situations aside from myeloma where you can get an abnormality in the serum free light chains. If the ratio is normal, but they're both elevated, it will often reflect renal impairment. The fact that the ratio is normal means they're being excreted at similar rates. So it's more reassuring from a hematological perspective. However, their renal function would need to be looked at a little more closely. If it's just one, either kappa or lambda is elevated and it's only very modestly elevated with a normal ratio and everything else is pristine, then I think that probably is reasonable to say repeat in 6 months. And if the trend is upwards, it's very reasonable to refer for hematological evaluation. If it's sort of sitting at 20 or 25, and again, the patient is very well, the kappa to lambda ratio remains completely normal and there's no paraprotein, it's very reasonable to watch it. It may actually not be an Mgus, but it might be a monoclonal B-cell lymphocytosis. So I would always perform peripheral blood flow cytometry in those patients because there may just be a small MBL that you could very comfortably watch.
Great. Okay, the next question is, what are the common side effects of Lenal Omide?
So lenalidomide is a great drug because it's easy to take. It's a tablet. Lots of people have no problems with it. You can do dose reduction. However, it can be very problematic. And most commonly, we see patients who come and say they've got tingling in their fingers and toes, a sensation of cotton wool. Sometimes it's quite painful. It tends to ascend up the arms and legs as it progresses. If we see that, we will institute dose reduction fairly quickly. Lenalidomide is also, it increases your risk of developing blood clots, so venous thromboembolism, which is why we put all patients on some form of anticoagulation, whether it be aspirin or a DOAC or Clexane. Sometimes patients have quite significant cytopenias on lenalidomide, and it's often quite unpredictable. Some patients are extremely sensitive and need to be on tiny doses in order to maintain a reasonable blood count, and that can sometimes keep the plasma cell burden at bay. And the other things that can happen are gastrointestinal type toxicity or side effects, so constipation, diarrhea. Excuse me. Skin rash can occur, but it tends to occur early. And often when there's a skin rash, when a patient has just started myeloma, we think to ourselves it's either lenalidomide, Bactrim or allopurinol, and we can usually tease out which one. And most of the time, it's mild and resolves.
Okay, and our last question tonight is, diabetes is an increased risk for cancer, but multiple myeloma is apparently the commonest type of cancer. Why?
That I don't know. I'm sorry, I'm not sure. I actually didn't realize that.
Okay, that's great. Thanks. I'll look into that myself because that is a really interesting question. Thank you, Orly, for that informative presentation on myeloma. Now we'll move on to our fourth presentation for tonight. Our fourth presentation is by Simone Ray, who is our cancer clinical nurse consultant on the GP Cancer support line, which is based at St. Vincent's and the Kinghorn Cancer Centre. So we're very lucky to have Simone managing that phone line, and she's going to give us an update on the beneficial phone line, which is an integral part of the GPCanShare project. Thanks, Simone.
Yes, so thank you again, Rebecca and team, and Dr. Lavee for such an in-depth update and for kindly sharing your specialist knowledge with us. I always leave enlightened from your talk, so thanks for your time. Good evening, everyone. Thank you for the opportunity to very briefly speak of our 1800 GP line cancer support line service. As I've been kindly introduced, my name is Simone Ray, and I do have the pleasure of operating the support line along with support from our specialist team and my colleague, such as Mary, that you've had the pleasure to meet tonight. So when you call our dedicated 1800 GP line number, look, our aim is really to provide the timely specialist advice and support and outreach that to general practices that you seek. And this is for cancer services and care within the Central and Eastern Sydney Primary Health Region. As you can see on the screen, the support line is for GPs and practice nurses, and also for allied health at work in general practice. It's available Monday to Friday between 8 a.m. and 6 p.m. Look, our health districts, our health district cancer services and department resources are focused on assisting the GP and patient, as Mary explained, with the GPCanShare program. And so we will have your patients seen quickly for review and ensure that you're aware of the plans for treatment and care, and be really easy for you to access in your busy schedules. As the line is centralised, the service will connect you with the local GPCanShare cancer clinician team on site, the relevant team on site to action yours and your patient's needs, whether that's southeastern Sydney, districts, or the St Vincent's Health Network in Sydney. Call queries to date have ranged from, well, across the spectrum that you can see on your screen, and with quite an emphasis on treatment and symptom management queries, non-urgent rapid access for new diagnoses and onset of new disease symptoms for review and management. So in March and April, we have seen, I'm not sure if that's been your practice, but patients are coming forward with reporting symptoms to their GP team, and so we're really actively trying to gather them into our services so that we can acute care and primary care setting provide what the patient needs. We look forward to helping you manage your patients in the primary setting. And, you know, if you're worried about one of your patients and you just like a timely treatment or discharge update, please give us a call. We've also had the satisfaction of helping general practitioners get the results they need and their timely care for complicated multifactorial presentations. And you know, we are actively working with specialists across our teams to fast track patients, you know, and whose GPs and nurses are connecting with the service, just to provide that extra care. We really have been able to tailor our care plans to the needs, specific needs of your patients and GPs, and we're very sensitive to their comorbidities and socioeconomic backgrounds. So for more information, call 1-800-475-473, have a look at the PHN website for our cancer information, or the websites at our centres that we mentioned, including the St Vincent's and Kinghorn Cancer Centre. Really appreciate your time. We look forward to being of service in the future and liaising with you for your patients. Thanks, and hope you enjoy our next presentation.
Thanks, Simone. Always great to hear about the phone line and the assistance and advice that you can give to GPs and practice nurses. Last presentation tonight is from Meg Barnet, who is a medical oncologist and senior scientist specialising in gastrointestinal and lung cancer, with special interest in immuno-oncology and genomic sequencing. She's also based at St Vincent's Hospital and the Kinghorn Centre. We're really lucky to have Dr. Barnet presenting on COVID-19, vaccines and cancer.
So, hi everybody, my name is Meg Barnet. I'm a medical oncologist at Kinghorn, and I've just completed a PhD in immunology and work in the Immunogenomics lab at the Garvan Institute. My main disclosure about COVID is that I was not an essential worker during the last lockdown. I was at the coalface at home in this kind of situation. So I'm as sick of COVID as anyone out there. So I'm hoping that this presentation takes a novel look at the things that we may have forgotten about in the basic research about COVID that might help us in going forward as we move further and further away from that. My other relevant disclosures are that I'm very croaky because I've got some form of non-COVID infection from said children, and I'm coming off the back of a night with said children vomiting all night. So good luck to all of us. Tonight I'm going to cover the impact of COVID on cancer more broadly, which has been quite wide-spanning, and some stats on that are quite startling. Look at the impact of COVID infection in patients with cancer, and then move on to vaccination and look back at the evidence for the primary 2-dose protocol, the 3rd dose and the 4th dose, and then relevant to our patient cohort, how effective are these vaccines in patients with cancer? And then to give you an update on some original research that's happening at the Garvan that we would love your help with. So everyone started, when we look at the impact of COVID on cancer, there's an unmistakable impact on cancer diagnoses. And we see in the curves on the left there, the period from January through April in 2019 compared with 2020, there's an almost 80% reduction in diagnoses of, in incidence of breast, prostate, and melanoma, which clearly we understand is not actually what's happening. There's similar data coming out from the UK, which is the curve on the right there. And we can directly link that with reduced screening. So we've got up to 90% reduction in screening for colorectal and breast cancer with colonoscopy and mammograms. And we presume that similar things are happening in terms of GP visits for PSAs and digital rectal examinations. So we're going to be seeing the impact of this, and we already have seen the impact of this in the clinic. I've seen multiple patients since I've come back who have late stage disease because they were not followed up promptly due to their reluctance a lot of the time to engage with healthcare earlier in the pandemic. There's been a significant impact on cancer research as well. Not only are a lot of our labs that previously focused on cancer now focusing on COVID vaccination, but a lot of the highly trained staff, both in the research and clinical setting, have been repurposed. We're getting less money, both because donors have come upon financial difficulty, but also there's more urgency in COVID research to attract donors. All non-essential experiments during each lockdown period were halted because of staffing issues largely, and because attendance on site was discouraged. So when you run mice experiments, for example, you need a whole network of people at the breeding facilities and on site to care for the mice and handle the mice. And when that's reduced, all of your non-COVID science grinds to a halt. People needed to take care of their kids, as you all know very well, and that had a big impact on scientists, disproportionately females, but that's obviously it was felt across families. Supply chain issues, as with supermarkets, a lot of the reagents that we need were not available. And also in clinical trials, patients were less willing to engage in clinical trials that sometimes needed more frequent visits or more prolonged time in healthcare settings. So we can see here the number of trials, both interventional and observational, reduced significantly. over the period from 2020 to 2021. Oh, that's my mice. So firstly, the first point to take out of this is that the impacts of COVID have been very broad spanning and are going to be felt for many years to come on cancer. Why do we really need to care about cancer, about COVID rather, in patients with cancer? And this was the point that did manage to get me enthused about preparing this presentation, because it is really important, and there's a big difference in outcomes for patients with cancer compared with patients without cancer. So firstly, the treatments that we give, including chemotherapy and targeted therapies, along with supportive medications such as steroids, increase risk. Cancer itself is immunosuppressive. Patients tend to be older, have multiple comorbidities, and they have high levels of contact with the healthcare system. The interesting, not so obvious reason that they're susceptible, though, are some finer points of interplay between COVID and cancer biology. So firstly, your protective barriers like your lung mucosa and your blood-brain barriers can be disrupted by cancer and its treatment, including radiation. ACE2 expression, which is the molecule on cells that allows internalization of the virus, is upregulated in lungs of older patients and of patients who are smokers, people who are smokers, I should say. And cancer is a procoagulant state, as is COVID. So they're at even higher risk of clot, which can add to morbidity and mortality. So patients with cancer are more likely to be infected with COVID. They're more likely to develop severe disease, and they're more likely to die. We first started realizing that this was a problem very early in the piece when some observational data came out of Wuhan, looking at 1,600 cases originally, only 18 of whom had cancer. But they found that of those with cancer, about 40% experienced severe events, which was a composite endpoint of ICU admission for assisted ventilation or death, compared with 8% of the whole cohort. So this was a very early canary in the mine, per se, that something was definitely different in patients with cancer. We then did a more specific study, again in a Wuhan cohort, looking at just over 100 patients with COVID-19 infection and cancer, and matched controls across the same 14 hospitals in Wuhan, and found that the risk of death in patients with cancer was more than twofold, and the risk of ICU admission was almost threefold. And we see on the column graphs below that the highest risk patients are those with hematologic malignancies, and second, the lung cancer patients, likely related to their other comorbidities such as smoking and poor baseline lung function. And then the graph on the right just shows that metastatic cancer has the highest risk compared with non-metastatic cancer, which is still higher than no cancer. So one further study that we looked at, that we did to prove without a doubt that how this was playing out, was in an American cohort, in a North American and Spanish cohort, using this COVID-19 and Cancer Consortium database, and this was published in The Lancet back in 2020. They looked at nearly 1,000 patients, all-cause mortality, and showed that about that significantly more patients who had either solid tumours or hematologic cancers died. So the primary endpoint there, the y-axis, is the proportion who have died of any cause following their COVID-19 infection. And we can see that there's a rate of about 10% in patients who have no active cancer at all, up to nearly 30% in patients with advanced hematological disease. And that's compared with a population rate of about 1.4%, so significantly higher. Independent risk factors that they found from this study in a population of around 1,000 were blood-based cancers, so Orly's problem, older age, male sex, smoking background, comorbidities, poor performance status, and active versus non-active cancer. Interestingly, the type of cancer and the type of anti-cancer treatment, the recency of surgery, and the obesity status didn't seem to impact. I'll briefly talk about management of COVID patients with cancer, or cancer patients with COVID rather. But actually, I think you guys are a lot more experienced in this than we are as oncologists. And we have an on-call person at St. Vincent's who manages COVID infections, who we call for advice when we need it. This site, if you haven't seen it, is fantastic and really easy to navigate and gives really good practical advice. So it's covid19evidence.net.au. The main point of discussion that we've had as a department, apart from when to stop treatment, which is in most cases a yes. So for most patients, we will stop any anti-cancer treatment. In some cases, if there's really high burden of disease that's rapidly progressive and the patient is clinically well, we may choose to continue treatment if there's appropriate facilities with isolation possible and things. We might continue that, keeping in mind that our chemo suite is full of immunocompromised people. But the main discussions we've had as a department is what classifies this immunocompromised status that is referred to a lot in the treatment guidelines. And actually active cancer in itself, solid organ cancer, doesn't qualify patients for a lot of the treatments, but we still have a very low threshold for giving treatment, particularly with sotrovimab infusions. But actually, I think today there's been PBS approval for oral molnupiravir and Paxlovid, so we will likely be using that a lot more. To meet some of these other criteria, if we're giving chemotherapy, then that meets it. And if we're giving reasonably high dose steroids, then that meets it. But active cancer in itself, which we know is a very high risk factor for severe disease, doesn't necessarily fit into those definitions. So the second point is that patients with cancer are at increased risk of illness and severe disease and death, regardless of whether the cancer is active and whether they're on cancer treatment. So we should have a very low threshold for treating them preemptively. Moving on to vaccinations. So vaccinations are fantastic, and you could give an entire presentation about the history, etc., which in itself is fascinating. A nice way to summarize them for patients, I find, is that they train your immune system to recognize part of a virus or bacteria, so that when it sees it again, it's got its army already prepared and ready to attack, per se. mRNA vaccines are different to historical vaccines that we've used previously. So the poster children for vaccination like smallpox, polio, and measles have been live attenuated or subunit vaccines. The main obstacle to using this approach with COVID is that they take a lot longer to develop and a lot longer to deploy over large populations. So mRNA vaccines were turned to in this setting, and they're not new. The first information about them in preclinical studies was published back in 1990. The technology focuses on the mRNA, which, if you remember back to med school, is the step between transcription within the nucleus of the DNA and translation of that code into a polypeptide protein in the ribosome in the cytosol. So the the mRNA segments that are used in these vaccines use a particular type of mRNA that's called non-integrating, meaning that once it's translated, it's physiologically degraded and there's no risk of insertional mutagenesis and things like that. So an mRNA vaccine, for example, the Pfizer vaccine encodes a modified version of the full length of the spike protein, which is expressed on the virus. And the Mrna encodes one of the glycoproteins within that spike, and it causes a transient increase in expression or a transient expression of that protein that then exposes to the B cells within the immune organs, particularly spleen and nodes and germinal centers. And then the B cells then generate a specific antibody response that's then preserved as memory B cells ready to mount an immune response on re-exposure to that antigen or that protein. Lots of antibodies can be produced against COVID-19. The particular antibodies that we're interested in are called neutralizing antibodies, and they're the ones that stop the internalization of the virus rather than just blocking the receptors. I'm not going to go through all these studies because you guys know them all, but I will talk briefly on one of the baseline studies to give an idea of where we started. With these initial 2-dose protocol vaccine studies that were really quite robust trials. And it seems like a lifetime ago now, but it's actually not so long ago. It's been time compressed into 10 years compressed into 2 in this setting. So the main vaccines, obviously, that we're using in Australia, Pfizer, Moderna, and AstraZeneca, all have a significant amount of phase 3 evidence behind them. For example, the Pfizer vaccine trialed, the first one that came out in December of 2020, a study with over 40,000 participants with the primary endpoint of efficacy against infection, so all confirmed infections, symptomatic, asymptomatic, and safety, and secondary endpoints of efficacy against severe COVID. And firstly, just looking at the adverse events down below here, we can see that they're mostly fairly mild pain at injection sites. They're mostly grade 1, some grade 2s, and the usual things that we would expect from a vaccination that effectively stimulates an immune system. So we saw from this vaccine that it was very effective by 7 days after the second dose. But actually the vaccine and placebo arms started separating after 12 days after the first dose. And had your maximal protection about 7 days after dose 2. So this is the poster child Kaplan-Meier curve from this study. They followed some of the patients out to 6 months and found that the protection against all infection was preserved mostly. And very significantly, they showed that the protection against severe COVID, which was having COVID and another signs such as respiratory failure, shock, or death or ICU admission, was excellent at nearly 97%, which is quite remarkable. So Moderna, similar numbers, won't go through it, similar story. AstraZeneca, similar numbers. The bad press received over this one was because the protection against infection was less. There was a 74% protection against infection, but actually the protection against severe disease was 100% in this trial, which is clearly on par with the Pfizer vaccine. So when there was limited availability, it was a very good option. So the 2-dose vaccination schedule is highly effective at preventing both infection and severe disease. We started to realize there was a bit of a problem with the longevity of the response when we started seeing increased infection and some breakthrough infections. So at more than 4 months after the second dose, we started to see, from a peak of 96% vaccine efficacy at 2 months, that it was reducing by about 6% per 2 months and had reached around 84% at the 6-month mark. All this data was when the beta variant was the prominent strain. Looking more closely at this, they showed, and this is one example of a lot of data I'll show from the Israeli Ministry of Health, because their data collection has been far ahead of a lot of other countries. We showed that severe cases in particular, all cases, but severe cases, were directly related to the time since your second vaccination. So looking here, they've split it up into 3 different age groups, and we see that there's not much severe infection at all in the 2 younger age groups, but in the over 60s population, that's clearly standing out. You can see an incremental increase in rates of severe disease the further someone was from their second COVID vaccination. The dark blue being those who'd had their second dose in January, lighter blue February, etc. So with this evidence of waning immunity, and also in time with the emergence of the Delta variant and the observation that Delta was occurring in vaccinated individuals, there came a push for a booster dose. And that was first rolled out in Israel as early as July of 2021. So early data again from Israel, and that's not what's on the screen, but leading to this study, showed that a 3rd dose given at least 5 months after your second dose was highly effective and reduced your chance of COVID infection over the ensuing 3 months by around 11-fold, reduced your risk of severe COVID by about 20-fold. There was a phase 1 trial that showed positive data, and with the emergence of Delta and increasing infections, a lot of countries implemented a booster dose based on phase 1 evidence and observational data, which is very unusual. So this is the phase 3 study that was actually only published a couple of months ago. And given how broadly we've rolled out booster dose, it's important to go back and consider what we see in the large phase 3, which is normally what we would base our our community-wide treatment decisions on. So this was a study in patients who were 16 years and over. About half of them were less than 55 years. And it was mostly quite reassuring, I think, in that there weren't many adverse events. But we do need to consider that in a population where there is diminishing benefit from sequential treatments, any severe adverse event is something that we need to pay attention to. So this 0.1% severe adverse events in vaccinated individuals were actually fairly minor. It was tachycardia and elevated liver enzymes. And that represented 3 people in this population of 10,000 or so. So the headline Kaplan-Meier for this looks very impressive. And it is impressive in preventing symptomatic disease. And I think it's a really important step for patients with any risk factors. And indeed, it's been shown to reduce transmission as well. So that's an important community protection step. But this endpoint is different from the earlier phase 3 studies that measured all disease, so included asymptomatic disease in that. And that skews, and that's an important endpoint in a pre-vaccinated population. So apart from the endpoint, the absolute numbers here we've got to pay attention to, and what's on the y-axis and the x-axis. So the timeline that we look at is reasonably small, over 3 months. And the absolute numbers of cases were quite small. So there were 5 COVID infections in the vaccinated group, so in those who'd received 3 doses. And there were 100 infections in those who'd only received 2 doses. So very small numbers. And then when you look at those with severe disease, it's even smaller. So nobody who'd had a booster dose got severe disease, and 2 patients who had their 2-dose protocol completed had severe disease. So again, we need to just think of this in the context of the potential adverse events. When we try to drill down into who is benefiting, we can again look at the Israeli data and look at a beautiful effect in the older populations, in the non-booster groups. This is severe infections, so quite a lot of severe infections, significantly reduced in those who've had a booster shot, which is a really important endpoint. The rate of severe disease in booster doses versus no booster dose in the younger age group, though, is really difficult to quantify. So when you look at all 3 of those age groups, they don't give a breakdown of how many in each group. There were 26 cases of severe disease in total across them, including those who'd had a booster shot and a non-booster shot. And so making a comparison statistically wasn't possible. So that's a lot of severe cases, too many severe cases for a preventable disease, but it's something that we need to consider where there are discussions of mandates and things like that with a vaccine that does have adverse events, as do all vaccines. So how does a booster shot impact our protection against Omicron? And it's actually quite good. So we see the issue with Omicron after just 2 doses was that the waning immunity was quite notable, and it was getting close to not being effective at all by 25 weeks after our 2nd dose in patients who just had the standard 2-dose protocol. When we look at a booster shot compared with sensitivity to the Delta variant, we see that patients who've had a booster shot have similar protection in the 3 months after their booster shot compared with patients who've only had two vaccinations to the Delta variant. What we don't know from this study is the impact on severe disease. We presume that then follows on that there is some protection from severe disease, which would be highly significant. So clearly we are recommending, we recommended a booster shot for all of our patients and for all adults and anyone that we can find any reason for. There is a low rate of severe disease in young and fit people. So that is something that we can assess the risk-benefit ratio for. The second booster shot, so the 4th dose, again, we look to the Israeli Ministry of Health data. So they initially looked at a 4th dose in their population of over 60-year-olds, about 1.2 million people in that database who received a 4th dose. And they showed that the protection against infection with COVID-19, which was predominantly Omicron variant at this point, waned after about 3 weeks following the 4th dose of vaccination. So trended back to what you're at after your 3rd dose. Reassuringly, however, the protection against severe disease appeared to be maintained. So I'll cover it in the summary point, but the 4th dose is something that certainly our patients, we're recommending for our patients, and they clearly qualify for it through the PBS guidelines. When we look at a young fit population, and this was a study done in Israel of healthy middle-aged to young healthcare workers and age-matched controls who received a 4th dose of COVID vaccination. They really found that it wasn't a very sustained benefit. So they showed that there was a bump in the antibody titer. This is the Pfizer vaccination in the middle here. So when you look at the neutralizing antibody titer, after dose 3 on the left and dose 4 in the middle there, you do get a bump in your neutralizing antibody titer. But when you look at the overall infections in that group, there was not a lot of difference. So 25% in the control group who'd had 3 vaccinations, 18.3% in the group who'd had 4 vaccinations. And they found that this effect waned after 30 days. And both groups, those who'd had 3 and 4 vaccinations, had really negligible symptoms. So I think we can confidently say, that the second booster dose in elderly at-risk patients appears to give a sustained protection against severe disease, and so is clearly warranted. The second booster dose, so the 4th dose in young people, really seems to give little benefit, and certainly nothing that's maintained beyond a few weeks. So that does not seem something that's promising. What about vaccination in cancer patients? Oh my gosh, it's getting late, sorry. I will cut to the chase with this. So we've shown that patients with cancer tend to seroconvert less effectively with a lot of vaccinations. This was the first prospective study looking at that and showed that cancer patients do have lower antibody titers following vaccination. So this is the Pfizer healthy controls on the left here and in each setting, and CanVax cohort patients, so patients with cancer studied in North America on the right. Consistently, the antibody titer following vaccination is lower in patients with cancer, but consistently they're mounting effective antibody responses that are above well above the cutoff level. Interestingly, the Johnson & Johnson vaccination does not appear to be effective in producing neutralizing antibodies, which I don't believe we use in Australia anyway. Patients on chemotherapy have the lowest antibody response to the vaccinations, and really interestingly, patients on immunotherapy actually had a higher antibody response to vaccinations. So from this, we could see that most patients with cancer achieve protective levels of neutralizing antibodies, and that the Johnson & Johnson vaccination was not a good idea in patients with cancer. Briefly, to finish with the research that our lab's doing that we would love your help with as GPs. So Deborah Barnet, I work with, is working on COVID vaccination currently. This was a recent article she published in Immunity, which is getting a lot of attention. Current vaccination strategies focus on this receptor binding domain part of the spike protein that's variable. So the parts of the receptor binding domain that we target with most of our vaccinations are highly variable, and they're not conserved across coronavirus species and strains. The parts of the receptor binding domain that are not variable, that are conserved, are the ideal parts to target, but we haven't successfully been able to do that so far. So that's a problem when you introduce Omicron, which is the most highly mutated strain so far, with that receptor binding domain clearly distinct from the original Wuhan strain. And all of the other strains have had very minor mutations compared with Omicron. So the holy grail of this receptor binding domain is this class 4 site that's conserved against many different coronaviruses. We know that, so what we've been doing in our lab is immunizing mice with 3 different types of coronavirus. Firstly, COVID. A modified COVID. Secondly, the original SARS virus from the early 2000s outbreak, and then a related bat virus. The class 4 site that we're trying to generate antibody responses to is exactly the same across all of those 3 coronavirus strains. And interestingly, immunizing with the current COVID virus generates much less effective antibodies to COVID-19 than immunizing with the original SARS virus and with the related bat virus. So we can generate antibodies to this class 4 site, most of which don't block the entry of the virus into cell, but one of which did. So the vaccines that we're trying to develop should focus on those that can generate antibodies to a conserved site, because we're now seeing virus that's mutating beyond the vaccines that we have currently available. This might be stimulated more by precursor coronaviruses like the SARS-CoV-1 virus. So the next step that Deb is now doing, Dr. Barnet, I should say, is trying to look at what's the optimal antigen to use as a booster vaccination in patients who've already received 2 Pfizer vaccinations. And so we're looking at mice who've already been exposed to 2 Pfizer vaccinations. And what we need is Pfizer vaccination that you would otherwise be discarding at the end of the day. So the doses are given to mice. The excess would be appropriately discarded. There's full ethics approval in place. And 1 human dose can treat 60 mice. And this is the kind of translational science that leads rapidly to novel findings, such as the vaccinations that we're using currently. And anyone who wants to tour the facility would be welcome as well. It's remarkably ethical and humane how we manage our mice. So the final learning point there is that final 2 learning points is that most patients with cancer achieve protective levels of neutralizing antibodies with either the Pfizer or the Mrna vaccination, and that a universal vaccine that targets the conserved domain is where we should be heading to prevent strain-dependent evasion. So thank you to everybody in my lab, but mostly to the patients who were part of all of those trials. And that's it.
Thanks, Meg, for that really interesting detail on vaccine data and the amazing work you're doing at the Garvan Institute. It was really interesting. You're one of those amazing multitasking people. I don't know how you do it with looking after children as well. We've just got a few quick questions. Now, the first one is, could you comment on recent evidence of fluvoxamine and fluoxetine protecting against COVID-19 infection and hospitalization of the order of 90% plus?
Disappointingly, I think I'm going to have to say no, as in I can't comment constructively on that. A lot of the medications that have been touted as potential treatments, there's been issues with the way the trials are set up. So I need to go back and read that study specifically. But the only study that's been set up really well with a treatment and control cohort is the UK dexamethasone study. A lot of the studies looking at ivermectin and hydroxychloroquine and stuff, they were negative studies, but a lot of them look at hospitalized patients only, and patients who are already enrolled in healthcare settings, so we'll have a lot of comorbidities only. So it's sort of something that you need to really read the detail in the study about the methods of recruitment, but I don't know that the evidence around those drugs in particular.
Okay, we've just got one last question, which is there any news on Novavax as a potential booster vaccine?
I'm also going to disappoint on that.
That's okay. If the people that ask those questions want to message their names, we might be able to give some more information. I'd just like to thank all our presenters tonight, especially thanks Meg for being able to present. I hope you have a sickness-free night. Also would like to extend our sincere thanks to all 5 presenters who are also clinicians working on the GPCanShare project. We really appreciate your contribution. As I mentioned previously, for further information on the services, please refer to the cancer management page of the assessment website. And lastly, I'd just like to remind everyone to complete the evaluation survey. Thanks for everyone's attention. I know it's really hard getting back into the swing of things, but it was great having everyone on board. Thanks again and have a lovely night.